this is part of the program too. The next thing that we do is we have a program on girls' health and safety program. It's based in Kwale County, and more so what we do there is we offer gender-based violence services and sexual reproductive health rights services to teenage mothers, young mothers, and young ladies in schools, teenage girls in schools that need our services. We follow up with them and make sure they get the services that they need. The fourth program is on the HIV program that we offer health adherence program in Western and Nyanza part of Kenya, where we have 4 hospitals that we support with the adherence program and support them by making sure that the patients come back to the facility to get their medications, follow up with them, make home visits, and sometimes even make sure that they take their drugs and nutritional support. The fifth and the last one is our program in Somalia, where we have 2 clinicians that run clinics in the IDP camps in Beledweyne and Mogadishu. And these clinicians have community health workers or community health promoters with them and midwives. And we are proud to say that we offer even delivery services to them. So we go from one IDP camp to the other, offering medical services. And all these actually comes from the fact that we are capable of offering our telemedicine services. Our digital health services are all consolidated in these programs, where every program, when they need expertise and help, we have more than 100 physicians in our platform that help us diagnose and treat the patients that are seen in these programs. So Dr. Paul Hart is one of the physicians that we consult and follow up on cases with. And we are very proud to say that we have more than 11,000 cases in our platform. So if you are willing to join us and be part of us, please let me know. I will be putting my email in the chat. So reach out to me, get to know more about the Addis Clinic. Something else is that in case during the webinar you have a question, please type it in the chat, and we will respond to it. Dr. Paul will be gracious to respond to it. In case you don't get, it doesn't respond to it as of now, he goes back and sends the response to us. So thank you so much, Dr. Paul. I will give you room to introduce yourself.
Well, thank you so much. I really, really appreciate being able to present here. Before I start, I always ask, and please, if there is a topic that any of the listeners want discussed, please let Anthony know. He'll relay it, because I don't know. I'm in the United States, and I don't know enough about what are the common problems that you'd like more information about, or even unusual problems in cases where you say, gee, I'd like to have a little bit more information, and let's have a talk about it. So please let me know. I will research and get back to you, and we'll do a presentation. Today we're going to talk about cancer, and what we're going to look at are the most common cancers in Kenya. So if we move on to the next slide, please. Oh, wait till, and thank you. Okay. From what I could gather from international data, 47,000 cases of new cancer are diagnosed each year in Kenya. 32,000 people pass away, and it's the 3rd major cause of death in Kenya. So it really is an issue that all those who are listening are facing every day. And unfortunately, women have a higher burden with higher cancer rates than men across all the cancer types. And so it is an issue. That's why I think it's important that we review it. I'm sure most of you know most of this data, and it's just an opportunity just to relook at it again. Next slide, please, Anthony. Okay, what are the most common types? Breast cancer, number one. Cervical cancer, prostate cancer, esophageal, and colorectal. So, you know, if you look at what you're most likely to see in your practices, wherever you are in Kenya, these are the five main types. Of course, breast cancer for women is a leading cause of cancer for women. Because of HPV, we have to worry about cervical cancer. That's not only in Kenya, that's worldwide, of course. And for those of us who are males, prostate cancer is the most prevalent form of cancer. Esophageal cancer is 11%. I mean, for whatever reason, it clusters in specific regions. This is the data that I got from international data. I don't understand why. And colorectal, you know, cancer of the bowel, it may be linked to diet and lifestyle changes. We don't know, but it's increasing. And this is something that at least, you know, these are problems you're going to see on a regular basis when you're seeing patients. Next, please. And there are regional differences. And certain areas have the Rift Valley, Western regions have higher prevalence of certain patterns. So I don't know where the different providers who are listening are practicing, but in your area, certain cancers may be more prevalent. I don't know how much that's going to impact you on a daily basis because you know you could be in an area where they have a lower risk but still have patients coming in on a regular basis as their diagnosis is cancer and you have to diagnose and treat them appropriately. Next, please. I think I froze. Anthony, did I freeze? Are we back?
I think you're okay. I think maybe Anthony froze.
Yeah, it's hard. There, oh, were we do? Oh, I think he's rebooting. Anthony, are you back?
Yeah, can you see my screen now?
Oh, I see your screen. Beautiful. I see you now beautifully. I think it was an internet thing where it just froze us.
Sorry for that. I think
No, that's not your fault. It's the internet. Let's go back and we'll carry on. You froze again. Uh, Jonathan, are you hearing me?
Yes, it looks like Anthony lost
I think
again.
they're, I hope they're not having, I had a problem with my internet the other day, which wouldn't load anything. I hope he's, looks like, I don't know. And there's supposedly some international problem with the internet a little while recently.
Like Anthony's back.
Anthony, you're back?
I'm really sorry, everyone. It's raining. It's raining in Meru.
It's not
So
you. We had, there's been some international internet problems. It's not you, Anthony, in any way. Believe me.
okay, okay. I think
Some major sites went down in the US just recently.
yeah. That's why I'm wondering why it's getting on and off. Sorry, everyone, for those that are joining us.
Good.
Can you
Okay.
see my screen?
If people can hear me now, okay, let's look at, we're going to start off with breast cancer because every year there are 6,800 new cases of breast cancer, and unfortunately, about 3,000 women die. So, what are the risk factors? What patient do you want to, who comes into you, are you going to be concerned about breast cancer? Is there a family history? You know, it's a woman, not only breast but ovarian cancer is a risk factor for breast cancer. Are they an older woman? So if a woman comes in who's 20, 25, you're not as concerned if they're in the 40s or 60s. Women who have a problem with being overweight, women who take more alcohol, and women who are either not had a pregnancy or started their pregnancies later in life. So what are you? How are they going to present? So a woman, history-wise, women may come in and say, "Gee, I just felt something in my breast. I have a discharge. There's some changes in my skin, or I noticed one breast is different than the other, or I was washing myself and I felt under my arm, and gee, there's something that's different here." So these are the how they present. But don't forget, if a woman is coming in with none of these problems, I think we should ask our patient, have you noticed anything different? And what I do recommend, and we know that monthly breast examination is really important. And what I've been saying for years to my patients, listen, you're bathing yourself. When you're bathing yourself,
So
you're washing your
inakataa
breast.
kushika
Use
next
that
au
time to do a brief examination. And if you do every time 1/4 of each breast over a period of a month, you've examined both your breasts fully a number of times. And if they get into that habit, the earlier we pick up a breast lesion, the better. And that doesn't mean that every lump in the breast obviously is cancer, every skin change is cancer, but it means that we want to investigate as their provider to make sure that it isn't a breast cancer, and if it is, that we can give the best treatment earlier on. I mean, very personally, I lost my mother-in-law from breast cancer. Hers was diagnosed way too late. So I'm very sensitive to this as a important things to do with our patients. Next slide, please. Okay, number 2, cervical cancer. Very common. 20% of female cancers are cervical. And why? Well, HPV is one, and that the type 16s and 18s are 70% of the cases. What are the risk factors for a woman? If they're early sexually active, if they have a number of partners, if they've had a lot of children, if they happen to have HIV as an additional infection, if they're smokers, and finally, if they've been on oral contraceptives for a long time. And these risk factors, it's easy to ask about. Sometimes you've got to do it very carefully when you're talking about multiple sexual partners, um, as far as, or when they started being active. But I started asking, I know this is a practice in the United States, women when they're 13 or 14 about sexual activity, very gently saying to them, I'm not singling you out, but do you have a boyfriend and have you been with him? And most women will accept that. And if the answer is yes, you give you an opportunity to educate them about the risks of disease, about the importance of checking themselves as time goes on. Okay, so what if the woman comes in and says to you, I'm having some problems? What are the problems she might present with? Abnormal vaginal bleeding after intercourse, in the middle of the cycle when she shouldn't be bleeding, or if she's postmenopausal, starting to bleed then. If she has pain that's persistent in the pelvis, if she has a vaginal discharge, which is often foul smelling, and of course, if the disease advances and it's no longer local, then you can get symptoms with the bowel and the bladder. So they're going to come in and say to you, gee, not only I'm having pain and some bleeding in the middle of the month, but I'm having some trouble when I'm passing my bowels or my urine. All of these are the information we'll take in. or you'll take in, you say, okay, in my mind, I've got to be really careful and check this woman. I'm worried she may have cancer. Personally, I never say that to a patient. I would say, well, let's just try and find out why you're having these, and I want to do some tests. And that, obviously is a vaginal exam, etc. Next slide, please, as we move on. Good. Oh, prostate cancer. 14.4% of males in Kenya. I don't know, actually, I don't even know the statistics in the US. The risk population, those of us over 50, I'm there. Strong family history. You'll ask your patient when you initially meet a patient, I would always take a family history. What illnesses run in your family? And if they don't say anything, well, has anybody, and then even if they don't say anything, I always say, well, has anybody had diabetes, high blood pressure, cancer? If they say yes for cancer, well, what types of cancer? Important. Um, your ancestry, unfortunately, with African ancestry, people have to have a higher risk for prostate cancer. Obesity and a sedentary lifestyle. The problem with prostate cancer is early on there are no symptoms. As time goes on and that cancer starts to advance, you can have frequent urination. They're getting up at night to urinate. They're going more frequently during the day, where they could say, yeah, sure, I would have breakfast, I would work till lunch, and then I would go again. No, I have to go in the middle of my morning's work. I have to go again in the middle, or as soon as my afternoon. If it's hesitancy, they go to you go to the bathroom and you're waiting for your urine stream to start. If your stream is weak, you know how your stream is when you're younger, it's a nice strong stream. Suddenly, it just sounds weak. Nocturia, of course, is getting up at night. Hematuria, blood in the urine. They may not notice the actual blood, but they may notice a change in color and say, gee, my urine seems a little bit pinkish tinge. It's not the same as it used to be. For us, it's easy to check with a urine dipstick. Again, if by the time we're getting discomfort and pain because of metastases, it's spread. But that is, those are the clinical presentations. And when a patient presents early on with some of these symptoms, when you're doing, and again, I don't know, each of us practice differently, but after I would go through why the patient is there, oh, I'm here for headaches. I'm a male, I'm 55 years old, I'm having headaches. I then say, well, irrespective of your headaches, let me do what I call a body scan. Do you have chest pain, upset stomach? And then you would ask, bowel issues, in this case, the urinary issues. You're getting up at night to urinate. Have you noticed any change in your urination, how the stream is? Do you have to stand there a little bit? And because they may initially not realize that this is a problem that's developing. They may have thought, oh, I'm getting a little bit older. How many of us don't feel that way? We get a little older. Yeah, that's what's happened. When indeed it could be the first signs of there's a cancer. So that's why it's important. Next slide, please. Esophageal cancer. I'm going to start off with a story about this. Years ago, I used to practice in Massachusetts. I had a patient who happened to be the minister of a church. And his first name was Barry. Barry came in and we started talking about something totally unrelated to something about the church, not related to medicine. And then he said as he was leaving, lately I've been noticing a little food stick in my throat. He had no risk factors, but he just noticed this little bit of problem swallowing. I ordered an upper GI, from an x-ray, and he had his esophageal cancer removed a week or two later. And I'll always remember that story, to listen to the patients. And if he hadn't made that statement to me and assumed that maybe, he ate something that upset his system and caused a little bit of acid, I don't know how long it would have gone on before I diagnosed it. Now, again, from international data, certain parts of Kenya have a higher prevalence than others. The Rift Valley and parts of Western Kenya. And the thought is that maybe due to something in the environment or something in the diet. Nobody knows for sure, but at least geographically. Presentation, trouble, dysphagia, trouble swallowing, and it usually starts with solids, and that's what he notices, my minister, and then it can progress to liquids. Over time, they have weight loss, chest pain, and regurgitation. Hopefully, depending on when your patients present, the earlier they present, the more likely we're able to cure them. What are the risk factors? Chewing tobacco and smoking, a lot of alcohol, interesting, very hot beverages and hot foods, and those people who are vitamin deficient, A, C, and zinc, and there are some carcinogenic toxins. So those are your risk factors, but that doesn't mean you have to have a risk factor not to develop this. So what you want to do is, again, it's part of your, if they don't present, as that's their presentation and they're there for another reason, I'm so used to just doing this body scan, you could pick it up. Because if the patient said, yeah, I'm here for my skin rash, and you ask the other questions, and that doesn't take long. We're only talking a few moments to go down from, headache, chest pain, trouble swallowing, etc. You may be doing your patient a wonderful favor and saving their lives. Next, please. Okay, colorectal cancer. Again, this is supposedly rising in Kenya. They're not sure. They think it's because of you're becoming more westernized and having the diet, because it's a big problem here in the United States with processed foods, red meat, reduced activity, all the things that we do here in the United States, which are not healthy. Warning signs: rectal bleeding or blood in the stool. Not everybody, unfortunately, notices that. If there are changes in your bowel pattern, suddenly somebody who's had a regular bowel pattern suddenly says, I've been a little constipated lately, or started having diarrhea. Now, that could be from a dietary change, that could be from other reasons, but in the back of your mind, it's got to trigger, let's think of bowel cancer. Pain again, cramping in the abdomen, and there's many causes for that, but think of bowel cancer. Weight loss and fatigue. You know, there I'm not on a diet, doc, but I've been losing weight. I've been more tired than normal. And feeling it when you go to the bathroom, and this is more advanced, hey, I'm not feeling that I'm really having a normal bowel movement. And these are the things you think of. I don't know, and we'll get to it in a moment, I don't know how easy it is to get screening colonoscopies in different communities in Kenya. I mean, that is the sort of the gold standard, but we'll move to that. Next slide, please. Okay. So again, how do we identify? These are things we've just gone over. Your family history. So you've asked that if your family, your lifestyle. Are you smoking? How much do you drink? And realizing that patients not always going to give us all the information or the full information. Somebody may be a little embarrassed about the fact of the amount of alcohol they take. So they're not going to tell me, oh, I'm taking, 6 or 8 beers a day rather than 1 or 2. The sexual history, again, very personal, very difficult for patients to talk about. Um, but you can ask the questions in a non-judgmental, easy way with your patients. Because am a family doctor and I had patients who were recurrent with me, after a while they become more comfortable and it's easier to ask those questions rather than at the first visit. That doesn't mean you shouldn't ask them initially, but they may be more likely to open up to you over time. And then your symptom review, when you go through from top to bottom, as we're talking about any new lumps, bleeding, pain, weight change, etc. So this is basically what we've said before, just here. And all these slides are available to you. If you request it from Anthony, he will send you all the slides we have here for you to use and to, just keep someplace if you want to review them. Next, please, Anthony. Okay, so what do? Breast exam. when we do our breast exam, we're looking for a mass which has irregular borders, skin changes, if the nipple is retracted or deviated, any discharge, and when we're feeling the axilla, are there any lymph nodes there? Cervix, and again, I don't know the background of all the providers, whether you all do. I used to do pap smears in my office, but some women prefer going to a specialist. Um, but what does the surface look like? And is it irritable? Is it bleeding? And of course, you do it. The prostate exam, when you're doing your rectal, is the gland symmetrical? Does it feel the same on both sides? Is it really hard and firm? It shouldn't be that way. And is it fixed as it advances? The esophageal signs, by the time you're getting the malnutrition, the wasting, the lymphadenopathy, and signs of dehydration, you've got advanced disease. Early on for esophageal cancer, you're not going to see anything. The patient's going to come in with the history we discussed, and you're going to say, okay, well, I'd like to do some tests on you. Hopefully they're available. And by the time you're studying these signs, is one thing. Again, the same for colorectal cancer. By the time you're feeling an abdominal mass or a mass on rectal, or the spleen is enlarged, or there's fluid in the abdomen, you've got an advanced case, and that patient is at much higher risk for problems and cure. Sometimes we're just able to palliative care. Next, please. Okay, what lab tests do you want to do? Now, I was having a discussion just before we started. I don't know, unfortunately, all the tests that are available to all the providers. And I know it varies as it varies in the US. If somebody's in a small remote community, the patient may have to travel quite a way to get a CAT scan. They may only be able to get basic lab studies. So this is a list of ideal, and you do what you can, and you refer if it's possible and appropriate. So breast cancer, after you've done your exam, a mammogram, an ultrasound, and then if they're younger women for high risk, an MRI. And it'd be nice to say, yeah, we have an MRI available in all sites. That's not the way it is in the US, and I know it's the same in Kenya. The ideal, the final test is under the microscope, a tissue diagnosis. An eye doctor or a surgeon, you do the biopsy, you look under the microscope, and you say yes or no. This is malignant or it's not. Again, cervical cancer, your pap smear. You want to know about HPV testing. We're going to look at the cervix, but again, to make a diagnosis, it's the biopsy. They go in, use the colposcopy, and you get a biopsy. PSA, the blood test is greater than 4. It's concerning. Greater than 10, really suspicious. And if you have a patient who is your regular patient, and once a year or every other year you do a PSA and it comes back 4 one year and the next year it's 7, you're going to be concerned. It hasn't reached a 10 yet, but you're going to be concerned for some reason. And then again, the ultimate test is doing a biopsy. And in the United States, and I'm pretty sure it's the same way, patients are giving us some sedation when they have the biopsy done. Esophageal cancer, the first is the barium swallow. That's what picked up my minister, where they saw something. And then as you move on, you do a CT scan. The ultimate test, again, is the biopsy, your upper scope. And they do a good number of biopsies just to look, is it and what type? And then finally, for the bowel, you're going to do a stool for occult blood, the fecal immunochemical test. Ultimate test is a colonoscopic exam, and so they can visualize. And you can do a CT colonoscopy as an alternative. The only problem is, if you say to a patient, okay, I know you don't want to have all the prep and have the tube put in and be put to sleep for your colonoscopy, we can do a CT scan. The problem is if they see something, they've got to go back and have the colonoscopy to have the biopsy to see if it is a benign or malignant polyp, if that's what they see. And another story is I had a patient who I every 6 months when he would come in for what I probably said, have you had your colonoscopy? He was a gentleman in his 50s. No. Finally, he said, okay, you'll stop bugging me. I'll have my colonoscopy. We picked up his cancer of the colon. And fortunately, he was cured, but had he had it done earlier, it would have been easier for him. So again, colonoscopy, the gold standard. Um, if you can get it for your patients, again, I don't know what's available always in Kenya. Next slide, please. Okay. And then what test do you do? Once you want to do a baseline, if you come back and you say, okay, I think my patient has got cancer, what am I going to do now? Your routine CBC, liver function studies, especially if you're going to be considering things like chemotherapy, your kidney studies, and HIV, which I know is tested. These days we're all sensitive and we do the test. And it makes a difference for certain forms of cancer, aggressive cervical cancer, and the treatment by the specialist. And again, I'm only primary care. I'm not a cancer specialist. They may have to modify the treatment depending on the HIV status and of your patient. And also makes a difference drugs they give. If we know that somebody has compromised liver or renal function, say compromised liver from too much alcohol, and then you do what's called staging studies. So once we made the diagnosis, where is the cancer? Is it just at the site we found it in the breast or the colon, or has it started to spread? For the chest X-ray, has it gone to the chest? For the abdominal ultrasound, liver, kidneys, and your lymph nodes. And CT scans, much more comprehensive. And for a bone scan for prostate cancer, and a PET scan CT, as they say, that's limited availability even here in the States and only for selected cases. So that wouldn't be a routine. But if you pick up your patient, and again, I don't know in Kenya, I would work with the specialist. So I may say, once we've made the diagnosis, I would say to the specialist, okay, I'll get the blood test for you. I'll order the chest x-ray, the ultrasound, and send it off to them and then work with them. Next, please. Okay. And then this is slide before we just went over, is where do you get treatment? And in Kenya, it's different than the States. Breast cancer, certain um, surgery, systemic therapy, radiotherapy. It all depends, I think, just like here in the States, in a smaller community, they're not going to have a cancer specialist. I was last week in a community of 3,000 doing a volunteer medical clinic. They had one primary care doctor. If somebody had developed a cancer, they had to travel to another center to get the treatment. Same for the prostate. And this slide is also, and for Kenya, I don't know the sites, um, but you would have to. I'm sure you folks know where you would refer your patients with the various cancers for treatment. Um, Next, please. Okay. And then there's chemotherapy centers. I guess there's 10 across the country. There's radiotherapy. It's centralized, I guess, in some of the national hospitals and private hospitals. And late presentation is a significant problem, not only in Kenya, but all over. If a patient comes very late, and just as a separate issue, and um, at a certain point in time, patients may ask you, am I going to survive? And what is treatment about? And again, I always tell personal stories. My late father died of cancer of the kidney. And after it was diagnosed, and initially it went to his lungs, he had surgery, and then when it spread to his brains, he said, I'm not going to do any more treatment. I respect that's a difficult discussion to have with the patient, but it's one I think is important. Um, and also, to back up one stage, when you're suspecting cancer and you don't know, um, I would never tell a patient up front, gee, I'm worried you have cancer. I would say, I think there may be a more serious problem here. Let us do the test. Now, if the patient came back and said to me, could that be cancer? I would say yes. I would never lie to a patient, but I don't want to needlessly worry a patient. So I say, let me do some tests and see what it is. And if it comes back as a benign breast lesion that you're going to, you may refer to have removed, but it's benign, you can say, great, this is a benign, not a serious thing. This is how we're going to handle it. If it comes back as a cancer, then I say, it didn't come back like I like. I have to send you to a specialist. And I always let the patient ask me the question whether it was cancer. And that's not a right or wrong, but I didn't want to burden a patient with unnecessary anxiety. And I didn't want to give them a false hope. But I would always say, we're getting, which is true, we are getting better and better results from our treatment these days than we did. I graduated 51 years ago. What we could do for cancer those days and what we can do for cancer today are two different worlds. And so as time goes on, there are new therapies, new techniques, new medications. So we are making remarkable progress around the world in that. Next slide, please. I'm sorry, Anthony. Okay, so right now, your national government is trying to prevent cancer, controlling tobacco use, encouraging HPV vaccination, encouraging healthy lifestyle, early detection, making more accessible treatment. And the other thing they're doing, which I hope we can help them do too with all the data we're gathering with the Addis Clinic, is give data, the more data that people have as to the frequency and the distribution and the types of cancer, make it for those who are planning a lot more meaningful to say, okay, or to see patterns or trends. So this is what the nationally is happening, which is wonderful. And this is something that was started in 2023 and is still ongoing for a few more years. Next, please. And I think we're nearing the end. Okay. And then, support. We talked a little bit about psychological support. In each community, I don't know what are available in your community. Some of the communities here in the US have great support system, others don't. But people can become depressed and anxious. And so besides treating the patient for their cancer, ask them questions about depression, anxiety, and treat them appropriately. As far as I know, this is off topic, as far as anxiety, I will send to Anthony a very simple technique, which is done by a Professor Herbert Benson at Harvard, non-drug technique to help with anxiety that you can teach your patients in a matter of 3 or 4 minutes and a way of handling their anxiety without resorting to a pill. You hate to add one pill and another pill, and especially if they're going on. If the patient is open to it, that's great. Palliative care, very important because if we reach the stage where it's past what we can do, and you're talking about something which is really aggressive, and the patient says, no, I don't want to put myself through it, like my late father. What can you do? The spiritual care, also talking about their end of life planning. I don't know enough about the legal stuff, but here in the US, a will, speaking to your family, what do you want done, when you pass? And then also, of course, there's the rehab. Somebody's had chemotherapy, had surgery. Do they need physical therapy to help gain back to the strength? What are they doing for pain management? Some of these cancers, if they start to spread, are very painful. And, I don't know what's available. We have pain clinics here in the US. I'm sure you have a similar type or referral base to say, how can we best help the patient if they're having pain? Be available to the family. Let the patients know and the families know that you'll talk about things with them. Not that you're going to solve all the problems, but often a family may want to reach out and say, tell me a bit more. What does this mean? What might happen? And then, of course, once we treat a patient for cancer, hopefully successfully, it doesn't mean that we're not going to keep monitoring that patient. If they've had one cancer, they could have another. So after they remove the breast cancer, the patient has survived, which is beautiful. Don't give up on monitoring that patient. Just like you keep checking patients for their blood pressure at ongoing visits, do the same questions we talked to from the beginning about cancer. And I don't know about community support groups. Some of the communities here in the US have them, some of them don't. Next, please. Okay. I don't think we need to do this one. This is just a case, but I think, Anthony, we should go to questions because I think we've talked about this. It talks about early detection. The sooner we detect something, the better we're going to do. And ideally, this is they talk about, no, ideally women are doing breast self-exam, people are aware of it. That's not always reality. Some of our patients do not do what we want. Some of them don't take good care of their bodies, and it's our job to try and help them as much as we can. Next, I think is there one more slide? Okay, challenges, expanded screening, education, more services, teaching us as doctors, and of course, research. And these are the challenges which are worldwide um, for not only cancer, but in this case, we're focusing on that. Next, if there is one, there, okay. And there we are. Early detection saves lives, prevention. We're going to strengthen our healthcare system. And of course, we are there to support every patient. And that goes without saying. I see we have a bunch of questions, Anthony,
Yeah,
if
we
I'm
have
not.
a few questions that we will go through as fast as possible because we have 15 minutes. I think the first question comes from Bernard. Says, "Hello, colleagues. Can failure to have daily routine partner who can
I'm sorry.
massage?"
I'm just, I don't know what's happened to my speaker. What was the question again, please?
The question is, can failure to have a daily routine massage of the breast attribute to breast cancer?
No, I'm still, it's my speakers are acting up. Let me see if I can read it.
John,
Um, can failure
yeah,
to have a daily, who can massage the breast? Can a failure to have daily routine partner? Um, I mean, there's nothing wrong with having massage. It's not going to cause breast cancer. Is that the first question about breast massage with breast cancer?
yes. Can you still hear me, Dr. Paul?
Yeah, no, I just opened up the chat and it says, can failure to have a daily routine partner who can
Yeah,
massage the breast contribute? Is that it?
yeah, you answered that. So the next question is, can chronic hyperacidity later become esophageal cancer?
You know what? I don't know whether that's a cause, but I'm going to look up that. There was one question before about recommending digital
Yeah,
rectal examinations. Yes, I think you should do that if the patient agrees on at your annual exam. You don't have to do it in every visit, but if that patient is your regular patient, if it's a new patient and you're doing a physical, definitely. I'm going to look up for about the if how, the relationship for chronic hyperacidity. Um, is the drug omeprazole, which is a PPI, available in Kenya?
yeah, it's very cheap and very much available.
Okay, let me give you some new information. The Mayo Clinic, which is, a major US clinic, looked at patients who had been on it more than 4 years. And often what happens is a patient starts on that and we're putting them on for a gastric ulcer. So you say, take it for a month. We're treating your H. pylori. it was part of, part of the process and stop it. Well, when they go to stop it, all of a sudden you get a rebound hyperacidity. So they say, oh, I'm still have a problem. You go back on it and they stay on it. And people have been on this drug for 10 years. What the research showed for the PPIs, with 4 years, there's a 30% increased risk of dementia from being on the PPIs. It did not show that for the H2 blockers. So yes, you use the PPIs, and if you want to come off them, um, suggest that you taper them. Don't suddenly stop them. That's just something extra. Okay. Um, can prophylactic prostate removal? I've never heard of that being. I'm sorry. I don't know if that is done. I'll double check. I know I did have a patient who had a positive history of breast cancer. So she went and had both ovaries removed. They did the genetic screening, and she died of ovarian cancer. Why? Because in utero, the ovaries migrate down to their place in the lower abdomen. A few cells stayed higher up. So when they removed the ovaries, they didn't know about these cells. They weren't looking there, and they became malignant. So that was only once in many, many years of practice. But prophylactically, I've heard about, women having both breasts removed and ovaries removed. And I don't know the situation there, but if a mother develops breast cancer and you can get a genetic screening done, if the woman is carrying the risk for breast cancer, then her children have to know about it. If her screen is negative for the gene for breast cancer, her children are not given that extra risk. So that's something that I would recommend. As far as risk factors, for colonoscopy is recommended once a year. For the next question, I lost everybody.
You're still on. I think Anthony just went off, so you can continue on. We all hear you.
Oh, others are here. Okay. So once a year colonoscopy. Now, that doesn't mean if you do a colonoscopy in January and in May, the patient comes to you and said, I'm having rectal bleeding and that's new and I'm having a change. It doesn't mean that you shouldn't look at that patient again and say, hey, I have to wait till January. If something has started to develop, you want to look at it. Mammograms, 40 to 50. But if a woman has a new lesion, that's different. I will find out. The next question is, what percentage do you think genetics is responsible for cancer? Let me get an answer for you on that, of the number of cases. Um, Cause of hair loss during the chemotherapy, it stops the hair follicle from working. You lose, we cycle our hair anyway. If you're not replacing the hair, there's your hair loss. I will look for any specific foods because I don't know. I know we talk about diet that have a higher risk of breast cancer. So what I'll do is by tomorrow, I will have sent Anthony a list of these answers and he can share it with everybody. Let's see, are there any other I don't see any other issues in the chat right now. If are there any other issues that I can address, please?
I think, Dr. Paul, sorry, my network is working up, and I'm so sorry for that.
No,
Have
wait,
you
no, no,
answered?
no, 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 no. This is, you know what? Again, please, thank you for participating, but please send me suggestions of topics because I
I will.
keep trying to think what's helpful, but I'm here in the US and I want to make it as valuable for providers in Kenya. I'm sorry I've never been to the country. I was in Ethiopia volunteering, but I never had the pleasure of coming to Kenya. I hope to be able to. But please let me know of any questions or topics you'd like. Are there any other questions, Anthony, that have come up?
Yeah, there was a question on I don't know whether you have answered it. Hair falling during, what is the reason
Yes,
hair
yeah,
falls?
okay, and I'll give a more detailed answer, but basically, as you know, our hair turns over all the time. The chemotherapy stops that process, so as we lose hair, we don't replace it. And that's why hair loss is so common because now our hair follicles are just not producing hair and they're losing what they have.
Thank you, Dr. Paul. I think that was the last question. And anyone else that has a question, I think, let me see on the question and answer. There was somebody, there's somebody
And
who
if there are
asked,
other and if I might say, if there are other questions, please send them to Anthony. He'll send it to me and I'll answer them. That's not ever a problem. And it doesn't have to be today. If you think of something tomorrow or next week, Anthony and I communicate all the time by email, so he could send it to me and I will get right back to him.
yeah, there was a question on how common is renal cell carcinomas,
How common is what, please? I'm missing it.
renal cell cancers.
Oh, I don't know, but I'll find out. Um, I will definitely find out about it. I mean, personally, I've had cancer of the kidney, so I know. And mine was picked up just for. I one morning I thought when I was voting, I said that looks like a little bit of blood. I had the ultrasound, and then they did the CAT scan, and I had it removed. That was 20 years ago. Thank God it was okay. But it's so important. I'll find out the frequency of that for you folks, and I will definitely get it back, all the answer back.
So we have Dr. Patrick Kubai from Meru University of Science and Technology asking, how can we get involved? How can we involve you in cancer baselines grant writing?
Anything, I'll
Do
do anything I can to help. I think this is an amazing group, and I must say, and I've said before to other folks, your providers working with extremely difficult cases, much more difficult than we see in the average US. You just let me know if you could reach out if I can help write a grant, if I can help getting some research for a grant. Be my pleasure, Anthony. You just send me the request and it'll consider it done.
yeah, Dr. Patrick, I will reach out to you, and we will communicate and know
Yeah, that's perfect
how to do it,
because yeah, that
how to
would
go
be
about it.
great.
Yeah, there's a question on how much is cancer genomics being applied in West, and how can we get it part of this world?
How much is, one second, let me pull it up. How much is cancer? Oh, I don't know. I'll look at that up. And how we can get Kenya involved, that's beyond my knowledge. I know the part of the problem with some of this is the costs are very expensive, and that becomes a real problem. Um, I'll see what I can get for an answer, and I'll get it back to you, of course.
Thank you, Dr. Paul. I think those are the questions for the day, and I think
Well,
we are just.
I will definitely get them answered and get back to you. And thank you so much, and thank you everybody for attending. I really appreciate you taking your time. I know it's in your evening there, and you could be doing other things, and thank you for coming.
Thank you for joining us, and thank you, Dr. Paul, for the presentation. For everyone that has managed to join us, in case you have a question, in case you want to know more about our programs, please reach out to me. My email is, and to Dr. Patrick for further follow-up on the same. My email is Anthony, Antony, at Addis Clinic. Addis is ADDIS clinic.org. No spaces in between. Anthony at addisclinic.org. My phone number is 0712 559 438. 0712 559 438. please reach out to me in case you have any questions about our programs, in case you have any questions about the presentation that we have, in case you have a suggestion for the next presentation, please reach out. I think as we close for the last part of the presentation, there's an anonymous attendee who has said, "Thank you, Dr. Paul. It was a very insightful presentation."
My pleasure, and thank you everybody again for attending.
Good night, everyone, and have a lovely evening. Bye-bye, everyone.
Bye-bye now. Thank you.